my case where the patient was planned for a left main PCI and there were a lot of complications. So, this is a 55-year male presented as unstable angina with normal LV function. He was diabetic, and this was the ECG showing a right bundle branch block. Unfortunately, I don't have the angio, so I have the initial CNAs from the guiding catheter. So the ileocaudal view shows LMCA is short and diseased with some uh, obvious calcium. The LCX is tortuous, and the mid or the distal LCX is showing 90% lesion. The proximal LED is showing stenosis. So the idea here was to send the patient for CABG, and because of certain issues, the patient was not ready. So this is from a periphery where CABG is a very tough job to explain to the patients. So what I had planned for this case, to just put a stent into the LCX and do a LMCA to LE cross-over stenting, a provisional strategy. So imaging was not available at our center, and we have the other things we have available at our place. So initially, I wired the LED and LCX and thought of first going to the LCX, but there was a wire wrap and the balloon was not going into LCX. So I thought just open up the LMCA, make some room, and then come back to the LCX. So initial dilatation with a 2.0 balloon and then a 2.75 balloon. So the lesion in the LED was very fibrotic, and it was not yielding. So took a 3.5 mm balloon, took 2 wires to create a cutting balloon effect, and then went up high pressures. Here the balloon has expanded well, and this is the picture. So I wired the LCX again, and then decided to go ahead with the LCX PCI first, and then look at the LMCA. So did dilatation at the LCX lesion, and took the LCX stent. So this was a 2.75 28 millimeter stent, and this was not a very hard attempt, but just try to go through it. So I mean, we don't use upfront guideliner, and it was not it was not decided that the stent won't go. So it was difficult in passing the stent, and with the maneuvering.
Of the circumflex. If you go back 2 views, something is happening to the circosteum.
Dissection. Basically, the left main, we wanted to create a dissection, sir, to give some space, and I think the same dissection has extended into the circ.
Did you dilate the ostium of the circ before putting the stent? Did you?
No, I didn't dilate the ostium of the circ, but I dilated the mid portion of the L6. Yeah, I didn't. Yes. Into the circ. So, could not pass the stent. And at this point, the stent got stuck. It was kind of degloved, and also if you can notice, the stent is crumpled inside the guide, and it was all stuck. So couldn't do anything. So all I could do is try to apply pressure, or before I could take the additional balloon to trap the stent, I mean the wires had come out with the pressure. So the first job I did is took out the displaced stent, and then the next shoot, by this time the patient had crashed. So he had low blood pressure.
See, at this time, taking out stent is now no emergency. Let it stay there. You can take it out tomorrow. At this point in time, what emergency is, you have a dissected left main, which is going into the circumflex as well into the LED. So you should just let those things stay there. Take a bigger guiding from the opposite groin. With that opposite, with second guiding catheter, you should be able to wire both into circumflex and LAD, because these wires are already taking the dissection. That dissection is kept tacked up, kind of partly stented by these wires. So take another guiding catheter, bigger guiding catheter from the opposite groin, wire into circumflex and wire into LAD, and have those wires deep. Because a wire only partly into the LED means only soft part of the wire is there. Your wire is kind of hanging. You can hardly take anything over it. Second guide, two wires deep in. One, those wires are deep in, so these wires will kind of stent the left main dissections. Now you do whatever you want to do the stent.
So in that attempt, as the wires came off and the patient had crashed, so took in the guide, then crossed the LED, started on inotropes, and almost no flow. Luckily, I was able to go through the LCX and rewire it, and somehow got some flow into the LED and some trickle of flow in the LCX. So did balloon dilatation of the LCX, and after that there was better flow, and the whole LMCA, the ostial LCX, had all dissected, and the LED also was diseased. So with this, decided to go ahead with first deploy a stent in the distal LCX 2.7528, and then the same balloon maneuvered, and then again after the stent was deployed, there was no flow in the LCX. So thought of doing a mini crush stenting. So took a 3.536 in the LMCA to LED and a 2.7524, and like the almost there was no time for anything, so deployed both the stents and got a TME3 flow, and this by this flow the patient's vital had picked up. So after that did the routine stuff of did a pot, high pressure, and then if I look at the LCM, it is all dissected, and the 3.5 stent which was positioned in the hurry had not covered the left mid ostium. So after the pot, I rewired the LCX, then dilated the stents properly at high pressures, 3.5 for the LED and 3.0 for the LCX. And so did a kissing balloon dilatation, initially each balloon at 18 and then both at 12 atmosphere pressures, 3.5 for the LED and 3.0 for the LCX. And this is the picture after. So here I can see that still there is a lot of haziness. Actually, there is a small branch which is coming on the LCX, and that obscures the image. And the left main still is not covered. Imaging is not there, and the flow is also not good in the LED. So I took a 4 into 12 stent. Initially, I had taken a 16 stent, but that was coming out more into the left main. So took a smaller one and then just positioned it in 2-3 views and deployed the stent and got a flow. The patient had stabilized, and when I was looking at the angio, I was still not happy. I thought that yet there is a lot of thrombus or left dissection uncovered, but it was more of a tortuous course of the LCX. When reviewed the case at depth after the procedure was over, the LCX had a very tortuous course which was overlapping with the left main image, and it was very difficult to see. So this was the final result.
Do you think you missed the Sir costume?
Sir, there is no. I did not miss the Sir costume, sir, because I had positioned the stent right at the Sir costume. So,
This is a dissected flat with the intramural
sir,
hematoma at the ostium.
Stents move, you know.
small branch overlaps at the Sir costume, and the LCX origin was like a very tortuous angulation. So in this view, it always appears as if there is a kind of haziness and thrombus, but that was the angulated course of that LCX that was giving the image. So
That is his.
basically, this case, what went wrong was not seeing the anatomy very clearly. Mainly the LCX is a very notorious artery, and it's very difficult when you overlook at the origin of the LCX. Most of the time it is a straight vessel, but certain times there is a lot of tortuosity, and which is, unless we take multiple angio pictures, we miss it. And guide induced dissections are very like a nightmare and catastrophic. So, and also upfront using the guideliner is the best strategy when we are dealing with whenever a LMCA disease, because LMCA is always calcified, fibrotic, and definitely there always will be a lesion at the ostium of the LAD or the LCX. So to avoid the complication, use the appropriate stepwise approach, what I have learned from my case.